And what we're going to have now is invite my colleague Ashish Jha from Harvard School of Public Health to join. This will be the interlude before our big closing conversation around getting your input. We'll have an hour and a half moderated conversation at the end. What Ashish and I will do for the next 20 minutes or so is summarize what we think we've learned and what we think we've heard to set up that conversation, to hear from you of what else, where else can we go, what else have we missed. So I'm actually going to step up and do the presentation here, and then let's see if this is. So this is just to summarize and capture. So the way we're going to divide this is I'm going to just remind folks where we've come from, what the charge was, and set what we came into today with. And then I'll turn it to my colleague, to Ashish, who will share his reflections on today and what he's heard, his reflections along the way as a planning committee member and as one of the partners in this endeavor. And as I said, our intention here is to set up the last conversation to say, you have to talk about this. You're not bold enough. You need to incorporate time. Just thinking through what more, what else we can do. So I'm just going to go through where we started, where we've been, just talk about a little bit about today, and then mostly the themes and conclusions from coming into this workshop, as opposed to, and Ashish will take us from there. So just to recall, it's been a four-way partnership between four institutions: National Academy of Medicine, Harvard School of Public Health, the Bipartisan Policy Center, and the Commonwealth Fund, with the Peterson Center for Healthcare in the middle as a funder. And the goal was to advance our understanding to better manage the health of high-needs patients through the exploration of patient characteristics, which you've heard a lot around, led us towards segmentation, and groupings, promising care models you heard from Arnie and from others, and attributes around that body of work, and then policy solutions. So you heard the panel around both among Medicare and Medicaid, but then also in the private sector and in other places, that how do you sustain and scale these models? It's been a journey. We started in February of 2015, so we've been at it for 18 months with the first workshop, and I'll go through just a little bit. Actually, we launched it in February of 15. In July, we held our first workshop in this room. Some of you were here. Second workshop in January of this year. Then the committee did a lot of work, and you heard actually some of that byproduct. So when we finished the first two workshops, we realized that there was some gaps in our knowledge and things that we needed to bring forward. And then we brought them here today, which is to share with you how far we've gotten, to receive your feedback in anticipation of a final report in March of 2017. So we've been working as we're going so that we'll put the report out more quickly and summarize the findings and our best thinking. In the first workshop, we were very intentional of just understanding who are the high needs patients, what are their shared characteristics and needs, what are successful care models. We've heard from folks across the country. Some of actually are back here. Karen Moore, I think, was at earlier workshop in Cambridge Care Alliance. So some of the ones that you read about in the journals and have heard about, have them come and talk about their models, share the evidence on that so that we begin to understand what they look like, and then begin the discussion around what the challenges are to sustainability, spread and scale of these programs. I think people are now using the term co-create because I think we're moving away from we could just take the PACE model. If it works in Indiana, it also works in Kentucky, and it also works in San Francisco. I think the notion that we're somehow just scaling things or spreading them is probably a linear, it doesn't capture the complexity of it. But I think our intention in the first workshop was to begin to highlight some of those challenges and to think them through. In the second workshop, we dove deeper. We began to look at the existing data, and Harvard presented there what became the framework and the underpinning for the segmentation. So what does claims, although it's been much maligned today, claims data still have feelings, and we should still, and particularly researchers who look at claims data have feelings too. So no, but it's been a helpful starting point. I think, Melinda coined the term the starter set. So we use that data to begin to identify, and Jerry's done it with other population-level data as well, to begin to segment the population and to understand what the limitations were. So I don't think it was just, we're going to use this data and this is all we have. I think it was to begin to appreciate how that holds us back from a true system that's kind of operating at the top its optimal functionality. Again, beginning the segmentation of the process, synthesizing what we know, and most importantly, and this is how we came to the mapping exercise, which I think we've gotten part of the way there that Arnie presented, which is the segmentation is only as good as how do you use it, and then how do you align it with the care models and the characteristics of care models, and putting that together into a real world setting. So I think that was a notion that we heard very clearly at the second workshop to drive us toward this. It's not just segmenting the population, it's actually around then what do you do with that information? How does that help us to move forward? And then distilling the key elements and looking at the spread and scale. And then we had a busy summer. I think my planning committee didn't like my euphemism. I call it the summer series, as if we were at a summer concert. It meant a lot of work for everyone to come and synthesize what we've learned and go forward. And thank you to the working group members who are not on the planning committee, but who put a lot of time into the taxonomy group, the care model group, and the policy work. I mean, people came and participated. But so we did these three things, which you heard today. And that really was what about the work that we did between what we heard in this first and second workshops. We put our best thinking together from the literature, from talking to experts, from convening people. And that's what we've been presenting to you today, to get your feedback and to say, are we on the right track? Have we gone far enough? What are we missing? And that's our workshop. So this is our futuristic headline. And actually, I'll give you a chance. Can people read this? Is it too small to read? Okay, so I'm going to give you a minute, because one of the exercises, I think it was Jerry Anderson, challenged us as we started to prepare the report, was write your, and I did not put a copyrighted news, because I don't want to get NAM in trouble, so I didn't put an actual news agency here. But this would be our one-paragraph headline, the lead in a story, if we wanted someone to write about the report. So as I said, the exercise was if you can't say something in a paragraph, then spending 147 pages to say something, we probably don't know what we're talking about. And so it'll be interesting as David kicks off the last session to have that in your mind about does it go far enough? Are there things that we've missed? We went back and forth. We actually spent 2 full meetings as a committee on just this paragraph to try to get clear, is it enough? Are these the right elements? What does bold mean? Do we think there's enough evidence to move forward that there are existing models that work? So if you hold this in your mind, you can take your phones up and take a picture of it. But I think this is an important piece as you give us your feedback in the last session. This is where we netted out at the U.S. News paragraph of our findings. And then I'll just summarize and turn it over to Ashish. Some of the main themes as we came into the workshop today, and I think you heard this, and again, I'll just picking up some of the key themes from others of the day. The high needs population is diverse, complex, expensive, and transient. And so a couple of the themes that jump out for me, one is incorporating the notion of time. And I'm not sure as a committee we've probably done enough of that. We use the word transient here, but I think using longitudinal, whether it's longitudinal data, whether it's time, I heard from you around the graphic that we need a dynamic, maybe we need a video to show that people move between them, or to David Labby around which box is first, and that's how you start it, and then you move someone through a progression. But so it really struck me, the element we captured as transient, but to be intentional in our thinking and how we move forward is that this is dynamic and it incorporates time and longitudinal nature of it. And I heard that very clearly across different sections. One size clearly doesn't fit all, and I think we heard that whether it's the policy environment, whether it's the care model, whether it's the payment model, and even I think we heard from Rick Kroenig, one using quality measures to drive payment and think that's the answer. One size doesn't fit all across the board. And so to me, that's telling us that we need to match the complexity of the population and of the challenge with the complexity of the solutions. And so there isn't going to be a single solution for any of this. And then we as a committee, and I think this is something that we didn't resolve, and we'd love to hear your feedback on it, is what's the right balance between standardization and customization? There are certain elements that probably should be standardized, and that we should hold and say whether it's leadership or you need accountability or measurement or multidisciplinary teams. So it can either be a how we do the work or what we're doing. And we also believe that it clearly has to be customized to communities, to families, to the care situation, to the community context, and getting some guidance for you on how do you put that into a report and make it meaningful without just writing, oh, there's tension that we couldn't resolve. So I think we as a committee have talked a lot. I mean, people glibly use the word mass customization. I think that's a great phrase and things, and we're not really sure, I think, what is entailed in all of that. So that's a place where, again, we'd welcome your feedback. Segmentation, we believe, is a tool that can be used in real-world settings. I think we heard feedback from you, and we actually heard the tension of what's the right level to apply it. Should we be applying it at the systems level? Should we apply it's the individual care? We heard, is it a triaging tool that use one time? Is it a feedback loop? So thinking about segmentation and where it fits into the system and who uses it, I think is an important consideration. And this one, I think we heard ringing, 500% endorsement for the fourth bullet. The solutions must, and across the board, must extend beyond the medical because social and behavioral factors are essential to address. I think you all probably challenge us to flip it on its head and say there's sometimes when the medical solution shouldn't be first. So we might not even lead through the door of the medical solution. So I would find no one I don't think would agree. No one would agree with the statement it's only medical care. I think you would probably push us further if I am reading the room correctly that sometimes we should lead with behavioral or social, and medical care as a support to that and as complementary. I think that's. I mean, if I were basing on some of the comments today. And then thinking about actionable policy solutions must account for the system constraints and complexity. And I think we heard this, whether it's from Catherine or from Jerry and others. And this is also a tension around when we write policy, we tend to write the floor, and we tend to say what needs to happen. And if we don't actually have the answer and the outcome we want, we write in what the process is to get there or what the eligibility and requirements are. And so how do you use a policy framework? And we even heard it around providers and the tension around, do you just make sure someone asks about patient-related outcomes, or do you actually, it led to something, and what is it in between? And so just thinking as we move into a contextual policy environment, how do you manage that tension between driving to the process that we're ensuring, or that we set up the policy environment to enable an outcome while being sure that it doesn't lead to unintended consequences. This is a path forward. Hopefully you actually agree with most of this, because we don't, I think we're a little bit in trouble, but I hope that this is the beginning. This is a starter set. I'm going to borrow Melinda's term. This is a starter set for the path forward. This is our first step. It's a 10,000 mile journey, and it'll begin with this first step. Clearly more research and better data are needed. I think I might amend that based on Bruce's comments to say different data are needed. So it's not just more and better. It might actually be different and different data sources and different, kind of rethinking that more fundamentally. There are major policy barriers. I mean, I think in one of our meetings, I hope I don't call out Catherine here, but she at one point said, in a policy framework, you can't get there from here where we are. You need to step back and rethink some of these things, was based on her feedback from some of the interviews that she did, is that there was not a Medicaid 1915 X, Y, or Z that was going to help us figure our way out here, that we actually needed to step back in the policy environment and think about it more fundamentally. But in the meantime, we cannot sit back. There are high needs patients today, tomorrow, and the next day who are living with the current system and with our current kind of organizational structure, our current payment structure. So we actually have to take action while we're doing this work on the more fundamental rethink. So the health systems, and it's very great that we have some health system folks here today, working with the payers to better identify and target the high needs and work together to figure out how to test those best practices. And payers need to think about how to adopt, whether it's a public payer or a private payer. How do they actively support the adoption of these models so they aren't pilots that are the Camden Coalition or Cambridge or places that are interesting but are in one or two places. And finally, that policymakers need to continue the progress toward a value-based system. We do think while it has challenges, and we've raised some of them today, we think the movement toward a value-based system is directionally very supportive of better care for high needs patients and for this population. So that is the starter set. That steps maybe 1 and 2 on the full journey. But what I'm going to do is turn it to my colleague Ashish to share his reflections, and then we'll open it up. We have an hour and a half, so we have a long, or about an hour and 15 minutes of a discussion with you all about, okay, how do we move forward? Ashish.